Today we're talking about our four main tissue types, so just everybody should know that our four main tissue types are going to be Kleenex, we've got Puffs, we've got Angel Soft, and we've got Scotties. I'm kidding, kidding. It's Dr. Snyder here with your Chapter 4 discussion. We're going to be talking about the four main tissue types of the body here, so let's go ahead and dive right in. So when we talk about our four main tissue types, just keep in mind that when we're talking about tissues, we're not actually talking about the ones you're going to blow your nose with. We're talking about the collections of different cells that are going to group together to carry out a similar goal. Similar goals such as doing things like making up glandular tissue, making up things like muscle tissue, making up things like all of the different types of cells that will group together as groups of tissues to make up our organs. So let's go ahead and get into it here. Our first type of tissue that we're going to discuss here is going to be our epithelial tissue. So the epithelial tissue is going to be, when we take a look at the representation of all of our tissue by weight in the human body, the epithelial tissue is actually going to make up a rather small percentage of our total weight in the body. However, it's going to be one of the more ubiquitous types of tissues that we see throughout the body because it makes up so many different types of organs. So we're talking about with epithelial tissue, it's going to be what ends up covering exposed surfaces. So think of things like your skin is going to be an exposed surface made up of epithelial tissue. It's also going to be what lines the internal passageways and chambers of the body. So we're thinking about things like the linings of all of our organs, especially when it comes to the GI tract as well. And then, of course, our epithelial tissue is going to form our secretory glands. So we're talking about glands both in organs and then both on our external surfaces, things like oil glands and sweat glands as well. Our second type of tissue is going to be the connective tissue. It's going to be a rather broad category of tissue here that we see making up almost half of our total body weight, 45% made up by connective tissue. But our connective tissue is going to come in a couple of different ways. It's going to be what provides our structural support. So we're thinking about our skeletal system as well as all of our ligaments and tendons as well. We have connective tissue used to store energy as well. That's because our fatty tissue, our adipose tissue, is also a type of connective tissue. And then we do have our types of liquid or fluid connective tissue as well. That's going to fill internal spaces. Things like lymph tissue or lymph fluid as well as blood is all going to be considered part of our connective tissue. We have our muscle tissue next. This is going to be what makes up half of the total body weight that we see right here, 50%. And our muscle tissue, so this is a typo by the textbook here, but our muscle tissue is going to be what is taken up here in this yellow box. Our muscle tissue is going to contract to produce movement. So this is going to be our different types of tissues like our smooth muscle tissue, our cardiac muscle tissue, and our skeletal muscle tissue. They all contract to produce a movement. And then we move over to our nervous tissue. The nervous tissue is going to be one of our smaller categories that we see right here, making up only about 2% of our total body weight, most of that being taken up by our brain. But our nervous tissue is going to be specifically or specially designed to conduct electrical impulses, things that we call an action potential, because these action potentials are going to be how we distribute information throughout the body. Getting into the specifics of our epithelial tissue here, like I said, it's going to be the outer layer of our skin. So most of the tissue that you see on a person when you look at them is going to be made up of epithelial tissue. It's also going to be what is going to line our different body cavities. So we're talking about body cavities such as the thoracic cavity and the abdominopelvic cavity, but we're also talking about all of the different cavities inside our organs as well. So they're going to cover the walls of our organs because there are going to be many types of epithelial cells involved in creating secretory glands, things that can actually secrete different products like the hydrochloric acid in our stomach, or all of the different types of hormones that we find being created by the pancreas as well. Those are all going to be created by epithelial cells. And then we're going to end up seeing with our glandular tissue, we're going to end up seeing the glandular epithelial tissue being broken down into two different categories. We have our exocrine glands and our endocrine glands. The exocrine glands are going to be characterized by the fact that they secrete their product into a tubular duct. So this is going to be what we think of when we are talking about different types of sweat glands as well as skin oil glands. Those are going to be our exocrine glands versus the endocrine glands. Endocrine glands are going to secrete their products directly into the bloodstream instead. So we're thinking about glands like the thyroid gland as an endocrine gland. The major functions of our epithelial tissue is that it is going to be the main source of protection for our body, protect us from external factors, whether they are environmental factors or chemical factors such as sunlight radiation. That's all going to protect, or that is all going to help protect the body by absorbing that radiation and dispersing it through all of our different types of or different levels of melanin distribution in the skin, which we'll get to in a later chapter here. It's also going to be responsible for a lot of absorption, especially when it comes to the absorption in our kidney tubules. So our kidneys have small organs called nephrons within them, and there's going to be a fair amount of not only filtration of the blood happening in the nephrons, but there's also going to be a fair amount of reabsorption happening in the nephrons as well. Sticking with the kidneys as our example for this slide here, another function of our epithelial tissue is of course going to be that filtration that I just talked about in the nephrons of the kidney, especially in the part of the nephron known as the glomerulus or the glomerular capsule, easy enough for me to say. So the glomerular capsule is going to be a big area for which we see blood shunted into the kidney and then squeezed so that we can see some filtration between the glomerular membrane, where we're going to end up seeing different types of waste products and different types of old broken down substances as well. For instance, if your body is fighting off an infection and is breaking down all of those invading pathogens into dead tissue, then we're going to end up secreting a lot of that dead tissue through that glomerular capsule and out the kidney. It's a big reason why your doctors always tell you to drink lots of fluids whenever you're sick, so that your body can more quickly and efficiently filter out that infection out of your bloodstream. Makes sense. Moving on, we're going to see our epithelial tissue, of course, be a big player in the excretion, especially when it comes to exocrine glands, such as sweat glands. There's going to be quite a lot of secretion happening with epithelial tissue as well, especially when it comes to lacrimal glands. Lacrimal glands being our medical terminology for our tear glands or the tear ducts. Those are going to be lacrimal glands. And then we are going to see quite a lot of sensory reception happening with our epithelial tissue as well. Not by the epithelial cells itself, more happening by way of the nervous tissue that is associated with each of those parts of the epithelial tissue, like the small nerve endings that's going to be embedded in our skin and at the base of our hairs as well. Because we have so many different functions of our epithelial tissue as well as different forms of our epithelial tissue, we need to talk about how we classify epithelial tissue as well. We classify epithelial tissue in one of two ways. The first is based on the number of layers of cells present in that layer of epithelial tissue. The second being the overall shape of the cells in that layer of epithelial tissue. So we'll start with the layers. So it's going to come down to, is there one layer or is there two or more layers in our tissue sample? If we have a tissue sample that has simply one layer of epithelial cells to it, this is going to be what we call simple epithelial tissue. If we have two or more layers of cells in our epithelial tissue, this is going to be what we call stratified tissue. However, there are going to be rare instances where we end up seeing what's called a pseudostratified arrangement. Not very common, like I said, pretty rare, but this is going to be where we have what looks like two layers, but it's not quite there. We don't have a complete division of two or more layers in our pseudostratified. And then with our shapes of cells, of course, when it comes to the overall morphology of them, this is going to dictate the overall function of those tissues as well. So we have our squamous epithelial tissue. This is going to be our very flat, very thin epithelial tissue that we see right here. We have cuboidal epithelial tissue, cubed and shaped and conveniently named, as well as our columnar epithelial tissue, column and shaped and also conveniently named. When we put these two terms together, we can end up taking a look at things like a simple squamous epithelial tissue that we see at the bottom of the screen here. We have a simple cuboidal tissue, a simple columnar tissue as well. And when we have the stratified tissues, we can see our stratified squamous tissue that we see right here. We have our stratified cuboidal tissue and our stratified columnar tissue. Taking a look at epithelial tissue cellular characteristics, the first thing to note is that they are going to be very densely packed together. They're going to be very, very close to each other that we see right here in our artist illustration on the right, and they're going to be connected through a specialized series of contacts and junctions. Things that we see right here, like our desmosomes, as well as the hemidesmosomes that we would see down on the bottom, which will connect our epithelial tissue to an underlying layer of connective tissue. This is going to be very important that our epithelial tissue is supported and connected to underlying connective tissue, because the connective tissue is going to be what keeps our epithelial tissue in place. And when we come and take a look at some of the junctions that we're going to see up at the top area of our epithelial cells, this is going to be where we see what are called tight junctions that we find up here. Tight junctions are going to be a very important characteristic of our epithelial tissue cells, because tight junctions are going to give epithelial cells their waterproof characteristics. It's a big reason for why when we jump into a pool or the ocean, we don't just instantly absorb a whole bunch of water within us, because the epithelial tissue that makes up our skin has these tight junctions which give it a waterproof characteristic. In the same vein, it's also a big reason for why the food and water that we eat and go through our gastrointestinal tract does not just leak out into the rest of our body, because of these tight junctions. Another thing to note is that our epithelial cells are going to have polarity to them. That's because they're going to have an apical and a basal surface. We have an apical surface up top, which is going to be our surface which will come into contact with the internal aspect of whatever organ or whatever cavity that the epithelial tissue is lining. For instance, if this were to be a couple of cells lining our small intestine, the walls of the small intestine would be down here, and the food within the small intestines would be up here, coming into contact with the apical surface, whereas the basal surface would be furthest away from the food as it travels through your small intestine. Another important characteristic of our epithelial tissue is that epithelial tissue is going to be avascular but innervated. So avascular, if we take this and break the word down, A means without, and then vascular just is referencing our blood supply. So our epithelial tissue is going to be without a blood supply, but that's okay, because the tightly packed nature of our epithelial cells is going to be how our cells can actually transport nutrients and waste products between each other. So they don't need this vascular system to take over that function, because the epithelial cells already carry that out quite well on their own. The term innervated, though, this is going to be referencing the fact that tissues are going to be activated by different nerves. So having a nerve attached to a tissue and giving it information, giving it action potentials, this is what we call innervation. So The avascular but innervated nature is going to end up playing a big part in the fact for normally you would think that tissues that are avascular do not have high regenerative properties. So we're thinking about different types of tissues that are going to be very lacking in blood supply. Typically, they do not have great regenerative capacity, but when it comes to epithelial tissue has a high regenerative capacity because it is very, very active in cell division. There is a ton of cellular division, a ton of mitosis happening with our epithelial tissues. This is also a big reason why epithelial tissue epithelial tissues are going to be the most common types of tissues for which we see cancer because there is the highest rate of cellular division. We talked about in a previous chapter when we talked about the cell cycle, we talked about that synthesis phase as being part of that cell cycle. So if the cells of the epithelial tissue are constantly going through this cell cycle, they are constantly passing that synthesis stage, which opens up the opportunity for an increased rate of genetic errors. But this regenerative capacity is going to be driven by this high rate of cellular division. Think about whenever, for instance, you sprain your ankle or sprain any joint really. It takes a little while for that joint to be able to heal. It's usually going to be a couple of weeks before you have a full healing process. But when it comes to our epithelial tissue, you think about when you get a deep cut or if you just ate your pizza straight out of the oven before waiting for it to cool down and now you burnt your mouth on your pizza and you're like, why the heck did I do that? I should have learned the last 5 times I burnt my mouth on pizza. Anyway, so these burns in our mouth, which is lined with epithelial tissue, and the cuts on our skin, which is made up of epithelial tissue, these will tend to regenerate and heal rather quickly, usually in a couple of days for the instances of a mild burn in the mouth, or maybe even a week or just 2 weeks to heal a deep cut that doesn't require stitches. And this is all because of this high rate of cell division in our epithelial tissue. Going further into the junctions of our epithelial tissues, we see a great illustration on the right-hand side here of our tight junctions that we find right here, giving the waterproof characteristic to epithelial tissue. We also have what are called adhesion belts. Adhesion belts are going to be sort of the backups for our tight junctions when it comes to trying to maintain that overall waterproof nature. We also have what are called gap junctions. So gap junctions are going to be areas in between our epithelial cells that actually open up a line of communication between our epithelial cells. We also have our desmosomes. The desmosomes are going to be found down towards the basilar surface of our epithelial tissue. The desmosomes, along with the hemidesmosomes, are going to be our areas of strongest connection between our epithelial tissues as well as connecting to the connective tissues underlying the basement membrane of our epithelial cells. Now that we've covered the classification of epithelial tissue as well as the different morphologies of epithelial tissue, let's talk about connecting those things and talk about the 8 different types of epithelial tissue. So our first type is going to be our simple squamous epithelial tissue. And our simple squamous, of course, when you take a look at the term, you should note that simple means it is going to be a single layer of tissue. And squamous, being the morphology of the cells, means that this is going to be a very flat, very thin layer of epithelial tissue. Since it is a very flat and very thin layer of epithelial tissue, and of course, always remember that anatomy dictates function, so structure dictates function. So the structure of this thin single layer of epithelial tissue is going to predispose it to being very, very delicate, but very adept at functions like absorption and diffusion. So we're thinking about things like when it comes to absorption, we're thinking about the type of absorption that's going to be happening in the kidneys, and then the different types of diffusion that we're going to be seeing in the lungs. So the lungs are going to contain small structures known as alveolar sacs. These alveolar sacs are going to be covered in lots and lots of simple squamous epithelial tissue where we have the diffusion of gases occurring across this delicate membrane, where we see oxygen being pulled across the simple squamous membrane of the alveolar sacs, and then carbon dioxide being diffused out of those simple squamous epithelial membranes. Moving on to our stratified squamous epithelial tissue, this is going to be our multi-layered tissue that's going to have all of our different thin, kind of flattened shaped cells to them. So stratified squamous, because there's going to be lots and lots of layers to it, this is going to make stratified squamous tissue very good for resisting mechanical or chemical stress. So mechanical stress, like we would see on the skin as well as in the mouth, because we have lots and lots of stuff coming into contact with our skin throughout the day. So we need plenty of mechanical resistance to all of those stressors, as well as resistance in the mouth. We have a lot of force happening in the mouth when we go about chewing, a term that we call mastication. M-A-S-T-I-C-A-T-I-O-N. Mastication is our medical terminology for chewing. So we need to make sure that we have plenty of resistance to the mechanical forces of chewing in our mouth as well. Moving on to our simple cuboidal tissue, this is going to again be a one single layer of epithelial tissue with a cubed shape to it, and because it has this cubed shape, it's going to be very adept for absorption and secretion. So we're thinking about the secretion here with things like ducts. So for instance, things like what we would see right here, we see the lumen of a duct, which is going to be the open surface or the open area in a gland that we can see right here on this histological picture of simple cuboidal epithelial tissue. And then, of course, again, with the absorption, like we would see through the kidney tubules, as well as the different types of absorption that we'll see in the small intestines, that's also going to be another area that we'll find our simple cuboidal epithelial tissue. And then, of course, we have a very rare instance where sometimes we're going to see stratified cuboidal tissue found in the mammary glands. So the mammary glands are going to be the glands that we find around the nipple region. So this is going to be more seen in females, especially when we're talking about nursing mothers, because we need to make sure that our nursing mothers, while they have the ability to go about this process of secreting breast milk through the cuboidal tissue, we need to make sure that there's plenty of protection for the mammary glands as well. So we have multiple layers to that cuboidal tissue, because I don't know how many of you, I'm assuming many of you are going to be a little bit on the younger side, but for any of you who have gone through parenthood, you already or have gone through parenthood and gone through breastfeeding, you may already be aware that breastfeeding is not exactly a really straightforward and gentle process. Kids or babies rather, they just kind of grab on and just try to get as much milk out as they possibly can. So there needs to be a fair amount of protection for the mother present. We're also going to see before we talk about this one, let's move on to our simple columnar epithelial tissue. Our simple columnar is going to be one single layer of column-shaped cells, and because of this morphology, it's going to be very adept for absorption. So we're going to see more of our simple columnar tissue found in the small intestine. We have a small amount of the simple cuboidal, but small intestine is going to be mostly made up of the simple columnar tissue type. And then when we move on to our stratified columnar tissue type, this is also going to be rather rare because we do need to make sure that our stratified columnar tissue is present in areas where we may have some types of mechanical stresses present, like when it comes to the salivary glands, because we have salivary glands are present in the mouth, and we just talked about how the mouth is going to have a fair amount of mechanical stresses to it. So our salivary glands need to have these extra layers of protection to them in order to hold up to those mechanical stressors. Sort of the same thing with the pancreas. The pancreas does not exactly hold up to a lot of mechanical stresses, but there are a degree because the pancreas is going to be located inferior or underneath the stomach, and the stomach tends to go through pretty radical changes in shape and size depending on what or how much you've eaten. So if the stomach were to expand, it would actually push the pancreas down a little bit or rub against it. So it's a good thing that the pancreas is made up of a lot of stratified columnar tissue as well. When we move on to our pseudostratified columnar tissue, this is going to be the type of tissue that we typically see lining the respiratory tract that we see here in the airways. It's going to have the primary function is going to be that there's going to be plenty of cilia present all throughout the inner linings of our respiratory system, mainly to help catch any foreign debris as it enters our airways, so that way we don't have any foreign contaminants going all the way down into our lungs to damage those simple squamous tissues of the alveolar sacs deep within the lungs. And then coming on down to the very bottom here, we have our transitional epithelial tissue as well. The transitional epithelial tissue is going to be named because it actually changes its overall shape. And this is going to be where we talk about the urinary bladder, as well as, to a lesser extent, the gallbladder is going to be another example of this. We have two bladders to talk about here that carry out or are made up of transitional epithelial tissue because the urinary bladder and the gallbladder both shrink and expand based on their overall volume of contents. So this transitional epithelial tissue helps to allow for those bladders to expand and contract based on their need. Next up are glands. So like I mentioned before, our glands are going to come in one of two categories overall. To recap, those endocrine glands, this category is going to be the type of glands that releases their secretions into the blood. We're thinking about the endocrine system or the endocrine organs here, things like the adrenal gland, things like the pituitary gland, things like the thyroid gland, as well as some of the cells in the pancreas, like the islets of Langerhans in the pancreas. These are all going to be the type of glands that secrete their products directly into the blood for transportation. This is going to be contrasted to our exocrine glands, which are going to be the ones that release their secretions into ducts. So we're going to be talking about a couple of different types of exocrine glands here, but we're going to start off with morphology. So we have a simple tubular gland. This is going to be our type of gland that has simply one duct in it. And then we have what are called compound tubular exocrine glands. These are going to be the type of glands that have many different ducts present to them. And then, of course, we have over on this side our goblet cells. These are going to be the types of exocrine glands that are actually made up of just a single cell, where we end up seeing a large amount of product being or a secretion being made until that goblet cell can actually release the product into the duct of the organ in which that goblet cell resides. The different types of exocrine glands after covering the morphologies here. When we talk about the different physiologies or how each of these exocrine glands can operate, we need to talk about the categories of merocrine, apocrine, holocrine, and then our goblet cells again. The merocrine exocrine glands are going to secrete their products into a duct through exocytosis. So this means that these merocrine glands are simply going to allow the products to move out of the cells through diffusion, through exocytosis, going back to our previous unit. This is going to differ from our apocrine exocrine glands because apocrine glands, these are going to be the type of glands that will actually release their entire contents into the entire cell contents into the ducts of that gland, including the cytoplasm. So the apocrine glands are going to release their products, their secretions, and all of the cytoplasm, as well as a number of organelles in the cell, into that duct. And then our holocrine glands are going to be the type of exocrine glands that release their products into the ducts by simply lysing themselves. Lysing. They're going to destroy themselves as a whole in order to release their products. Now let's change gears and move away from epithelial tissue here and talk about our connective tissue next. So our connective tissue is going to have three primary categories. We have our fibrous connective tissue, our supportive connective tissue, and our fluid connective tissue. Our fibrous connective tissue is going to be made up of our loose and our dense fibrous connective tissues. Our loose fibrous connective tissues are going to create a very large open framework. We're thinking about things like our connective tissue proper is going to be what we call our loose connective tissue. So we have our areolar connective tissue. The areolar connective tissue is going to be the type of connective tissue that the body uses really more for like packaging material. You can think of it like packing peanuts. Whenever you receive a package in the mail, that's not really common anymore. I know people typically get their stuff from Amazon and whatnot now, and Amazon doesn't really use packaging stuff anymore. They might throw some paper inside the box. But back in the day, we used to use styrofoam called packing peanuts. And we would throw a bunch of these packing peanuts in with our packages to make sure that everything stayed nice and protected. And the areolar tissue is going to function in the body quite in the same regard. It's going to be a big player in things like shock absorption and things like decreasing friction between all of our internal organs whenever we move our body. Similar kind of thing with our reticular tissue. The reticular tissue is going to end up having a form that we see much like right here in the top of this picture that we see right here. These are what we call reticular fibers. They have more of a web shape to them, and that's because we use the term reticular in medical terminology to denote when something has a web-like shape or a web-like appearance to it. So the reticular tissue is going to carry out a function of being very elastic and very pliable to allow for our connective tissue to stretch in multiple directions and then resume its original shape once that external force has been removed. We also have loose connective tissue in the form of adipose. So adipose is going to be our medical terminology for fatty connective tissue. With our dense connective tissue, these are going to be the types of connective tissue fibers that have a very, very dense arrangement to them. Things like our tendons and our ligaments. Our tendons and ligaments, because of this dense fibrous arrangement, they're going to be very, very strong at resisting forces that travel along the path of those fibrous connective tissues. So we'll get more into what I mean by that at a later time, but for the time being, note that they are very, very good at resisting forces in the arrangement that the fibers are laid down. Moving on over to our supportive connective tissue, we're talking about things like cartilage and bone, the type of connective tissues that make up our skeletal system. So our bone is going to have two categories to it. We have what are called spongy bone and compact bone. Our spongy bone is going to be quite like the name implies. It's going to be bone that has more of a punched out sponge-like appearance to it. We'll get into the specifics for why that's important when we talk about our skeletal unit. And then our compact bone is going to be what we're looking at right down here. It's a very compact, very dense arrangement of bone that's going to be very strong and very good for holding up our weight. When it comes to our cartilage, we have three main types of cartilage. We have our hyaline cartilage, we have our elastic cartilage, and we have our fibrocartilage. They're going to have their own unique characteristics to them, and we'll talk more about the individual aspects for why, but for the main part, our hyaline cartilage is going to be our type of cartilage that's going to have a very, very strong, almost immovable characteristic to it, but some slight degrees of pliability to them is going to be present. Our elastic cartilage is going to be the type of cartilage that we can actually bend and twist, and then once we let go of that tissue, it's going to resume its original shape. Think of your ears. Your ears are made up of elastic cartilage. And then we have our fibrocartilage. This is going to be the type of cartilage that's going to be extremely, extremely strong and allow for virtually no movement of the cartilage itself. That's not to mean that it doesn't allow for movement of the structures around the fibrocartilage, however. Moving on to our fluid connective tissue, we have, of course, more categories. We have our blood fluid connective tissue and our lymph fluid connective tissue. So our blood is going to be what is contained in all of our blood vessels, and then our lymph tissue is going to be what's contained in our lymphatic vessels. We do have a little bit of overlap between the two types where we have our white blood cells, especially when we have white blood cells that need to dump off excess waste products or broken down materials into the lymph nodes for processing. We will see those white blood cells actually travel from the circulatory system, the blood circulatory system, into the lymphatic circulatory system. Primary functions of that connective tissue is going to be much like what we've already talked about when it comes to our skeletal system. It's going to establish a structural framework of the body. When in the case of our fluid connective tissue, it's also going to be responsible for transporting fluids and dissolved materials. In the case of our skeletal system and cartilage, it's also going to be responsible for protecting delicate organs. This is also true with some of our loose fibrous connective tissue, such as adipose tissue, as well as the ability to support and surround and interconnect other types of tissues. That's another key aspect of things like our adipose connective tissue. And our adipose connective tissue also stores energy, especially in the form of triglycerides, because we talked about in our previous unit that triglycerides are going to be one of our primary building blocks for adipose tissue. And then, of course, again, in the responsibility of our fluid connective tissue, like our white blood cells, it's going to be responsible for defending the body from invading microorganisms like bacteria, viruses, sometimes even prions and fungi. Some of the other characteristics of our connective tissue is that obviously they vary widely in their location and function, but more importantly, they're never exposed to the surface. That's going to be a pretty bad day when you see a patient or a patient comes to you and they have various types of connective tissues exposed to the surface, like if blood is leaking out of a wound, or if they broke a bone and the bone has pierced the skin, for instance. Our connective tissue is also going to range pretty widely from having highly vascular properties in the cases of things like our bone. That's going to be a highly vascular connective tissue versus something like our adipose tissue, which is going to be highly avascular. We also may see much of our connective tissue contains sensory receptors in order to give us indicators about things like joint position sense or pain, which was what we would call proprioceptive information for joint position sense, or nociceptive information for things like pain. But when it comes to our connective tissue, they all have three main components. They all have highly specialized cells. They all have an extracellular matrix as well, made up of two parts: extracellular protein fibers and ground substance. The ground substance is going to be mainly just this gelatinous material that's going to be most of the filler in our extracellular matrix of our connective tissue as well. But before we move on from this slide, I want to take a quick moment to talk more medical terminology with you all, because when we take a look at words that we see right here, like fibroblasts, osteocytes, and chondrocytes, this is another excellent point or another excellent time to practice your medical terminology and break the words down. Because if we look at the root parts of each of these words, it tells us the exact information about what we need to know for what this word is referencing. In the case of a cyte, C-Y-T-E, this is going to be our medical term meaning cell. So when we're talking about cytes, we're just talking about any type of cell attached to the root word here. In the case of something like osteo, osteo is going to be our root word denoting bone tissue. So an osteocyte quite simply means a bone cell. Same sort of thing when we talk about chondro. That's going to be our root word for cartilage. So when we talk about a chondrocyte, we are talking about a cartilage cell. When it comes to things like a fibroblast, though, another important aspect to think about when we talk about medical terminology, an important concept to keep in mind here is just to think about when it comes to blast cells, think that blast cells build. So if we have blasts with a root word like fibro, we're thinking about fibroblasts as being the type of cells that build new fibrous tissue, especially when it comes to things like our loose fibrous connective tissue. That's going to be a very big part of our fibroblasts' function. This is going to be on the opposite side of the coin for something like a clast cell, or C-L-A-S-T. A clast cell is going to simply do the opposite of what a blast cell does. So if a blast cell builds, the clast cell is going to break down. Just a little key bit of information to keep in mind as we move forward and talk about all the individual different types of tissues here. Now, these components of the extracellular matrix, like I mentioned, there's going to be two main parts to it. There's going to be a fair number of fibers and a fair number of ground substance. We'll start with the ground substance first. So the ground substance is going to be a very clear and colorless substance. It's going to be taken up by all of the pink that we see on our picture right here. Now, all of this clear and colorless substance that's going to be represented by the pink on the picture here, it's going to have a high degree of what's called viscosity to it. So viscosity is going to be a scientific measuring system that we use to describe how thick a liquid is. So a low viscosity liquid is going to be very thin. If you were to pour it down the side of a table, something like water, a low viscosity liquid like water is going to drip down to the bottom of the table very quickly, versus a liquid that has a very high viscosity, like our ground substance. This is going to be a very thick liquid. Think of something like honey. If you were to try and pour honey down the side of a table, that is going to be a high viscosity liquid that will take a pretty long time to drip down the side of the table when compared to something like water. Now, this high viscosity is going to be due to the high presence of proteoglycans and glycoproteins in our ground substance. Now, inside of all of that ground substance, we have all of our different types of protein-based fibers making up the rest of the extracellular matrix. We have a couple of different ones to keep in mind. The first one is going to be our collagen fibers. These are going to be the yellow fibers that we see down through here. These are going to be very thick and very, very strong. These are going to be the types of fibers that we see in things like our ligaments and tendons as well. We also have elastic fibers. Elastic fibers are going to be these very slender ones that we see throughout here. And much like the name implies, they are going to be very stretchy. They're going to allow for the tissue itself to be pulled in one way or the other and still maintain its original shape once that external pull is removed. Our reticular tissue is going to be seen right over here. It's going to have that web-like appearance, and again, reticular tissue is going to also work in conjunction with the elastic fibers to help allow the tissue to maintain its shape and resist too much force or too much external force pulling the tissue in one direction or the other. With our loose connective tissue, we have our areolar connective tissue is going to be the most common type of loose fibrous connective tissue. The areolar tissue, like I said, is that packaging or that packing material in the body. It's going to be really, really ubiquitous in the skin, especially as we take a look at a cross-cut of our skin, or the integumentary system here is what it's known medically. And we have a fair amount of extra space that we need to fill in between each of all of those epithelial cells that make up the epidermis, or make up the integumentary system as a whole, rather. And so we're going to end up seeing this layer of the skin that we see right here is going to be called the papillary layer. And this is going to be mostly made up of our areolar connective tissue. We also have a fair amount of adipose tissue, which is going to make up most of our loose connective tissue volume, especially when it comes to where we find it in areas of protection, such as pads around the eyes and the kidneys. We have a fair amount of fat padding around our kidneys to both protect them from forces, but also to help secure them to the back of your abdominal wall. This is an excellent clinical point so it's a real hot button topic, weight loss. And there's a lot of people out there going through different types of strategies and things to achieve massive weight loss pretty quickly. But it's important to keep in mind that there is such thing as too much of a good thing. If you have too much weight loss way too fast, you can lose fat in key areas of the body, like around the kidneys. And the resulting condition of such drastic weight loss and a reduction in the volume of fat pads around the kidneys is that the kidneys can actually slide down the back of the abdominal wall as a result. That's really, really problematic because it actually impacts the ureters, or the tubes that leave the kidneys and feed urine into the urinary bladder. So if you get a kink in one of those because they've been compacted, that can be a huge problem for the kidneys. So it's very, very important that while weight loss is good, it needs to be done at a controlled rate. We also have underneath the dermal layer, or the integumentary system, a fair amount of adipose tissue present in what we call the hypodermis, because the dermis is going to be what we call the skin, and hypo is our medical terminology for meaning underneath. So underneath the dermis, we have our hypodermal layer made up of much of adipose tissue. And then we, of course, have that more of that reticular, loose, fibrous connective tissue that's going to provide a lot of the structure and placement for organs like the liver, the spleen, and the lymph nodes, as well as the bone marrow, which we'll cover more about the bone marrow in our skeletal unit. But when it comes to talking about internal organs like the liver, spleen, and lymph nodes, you get to cover those in anatomy and physiology too. Our dense fibrous connective tissue is going to be what typically is what we think of with things like our tendons, which is going to be what connects our muscles to our bones, as well as different ligaments, which are going to be the type of tissues that connects bone to other bones. So first we'll talk about our dense regular connective tissue. So dense regular connective tissue is named such because the collagen fibers that make up that connective tissue are all arranged in parallel bundles. So we see that right here on our histological pictures here on the right. We have all of these collagen fibers right in here making up our tendon from the triceps muscle. So these dense regular tissues, tendons and ligaments, they're going to be very, very adept in resisting forces that travel parallel to their fibers orientation. So for something like the triceps muscle, because the triceps muscle has this orientation where all of the fibers are going down in the same direction as the triceps muscle itself. This is going to be what makes the triceps tendon very good at maintaining the connection between the triceps muscle and the very end of our ulna. So when I mean they're very good at resisting forces parallel to their orientation, this also means that they're very bad at resisting forces that go perpendicular to their fibers orientation. So this is why, and now we're in the heart of football season, so this is why we see football players, they may have things like a non-contact injury. They may just kind of hurt their knee and go down in the middle of the field, and you wonder what the heck happened. And then it comes out later that they tore their anterior cruciate ligament, the ACL. And it has a lot to do with the fact that even though the ACL is very strong, and because it goes from the distal femur onto the proximal tibia to hold your knee together, it's very, very good at making sure that your knee maintains its contact. It's also very weak at preventing parallel forces that go parallel to the knee from tearing it. So any type of force, whether it's a cutting force or whether someone else runs into the side of their knee and they just take their knee out from the sides, that puts the ACL at a very disadvantageous state, really. It puts it in a very easy position to be torn, whether it is a grade 1 tear, grade 2 tear, or a full-on grade 3 full thickness tear. This is going to be an important concept to note when it comes to sports medicine as well as helping to care for your patients in the future. Now, dense regular tissue differs from our dense irregular tissue because dense irregular tissue are going to have fibers arranged in more of a meshwork pattern. This is going to be typically seen in the dermal layer of the skin as well as covering some of our visceral organs. Viscera, by the way, is a medical term that we use to describe organs found within body cavities, especially the body cavities of the thoracic cavity and the abdominopelvic cavity. So the organs that we find within that thoracic and abdominopelvic cavities, those are going to be referred to as the visceral organs. But the dense irregular tissue fibers, they're going to have this mesh-like appearance to them, and this is going to allow these fibers to resist forces in multiple different directions. It's a big reason why you can pinch and pull your skin in a couple of different directions, and when you let go, it resumes its original shape. However, because of this irregular shape to them, the dense irregular fibers are not as strong as the dense regular fibers. So that's a big reason why you can actually tear your skin if you have enough force that comes into contact with your skin. When it comes down to our elastic fibrous connective tissue fibers, these are going to be the ones that have much more elastin fibers than collagen. They have our regular orientation that we see right here. And as a result of that increase in the elastic fibers, they're going to they're going to be rather springy and resilient, and it's going to be where we find a lot of movement in our ligaments as well. So things like we would see the ligaments between the posterior elements of the spinal column right here. This is a cross section of the spine. We have one vertebrae right here and another vertebrae right here. But on what we call the posterior elements, we have a couple of ligaments down here that are going to be responsible for connecting those posterior elements of the adjacent vertebrae to each other. And it's a good thing we have lots of elastic fibers in these structures, because it's going to be what allows us to actually turn our head, move our body, twist our trunk, and allow our spine to resume its original shape once we go back to a neutral position. Without elastic fibers in our spine, we would all be walking around like Batman, right? We would all have to turn our entire body to the right every time someone tries to get our attention on the right, instead of just simply turning our head to look at that person. So our fluid connective tissue is going to be made up of our blood and lymph tissue. So we end up having lots of fluid flowing throughout the body with many different suspended proteins, especially things like platelets as well, found all throughout our blood that we see here. Now, when it comes to all of the different components of our blood, we have what is called the blood plasma, which is going to be the watery matrix, for which we typically are going to find all of our formed elements flowing throughout. The formed elements are going to be the red blood cells, the white blood cells, and the platelets. Now, our lymph system, this is going to be formed from a lot of the interstitial fluid that we would normally find throughout the body. So we're going to see the overall fluid circulation with our two circulatory systems is typically going to begin by having our oxygenated blood pumped from the lungs, which we would imagine are out here. They're going to be pumped into the left atria. The left atria of the heart is going to pump that blood into the left ventricle. The left ventricle is going to pump that oxygenated blood out to the rest of the body, where the oxygen will be dumped off in the capillaries. We have our water and solutes, our oxygen and other different types of nutrients, different types of sugars and things as well. Those are going to exit the capillary bed and go straight to their target tissue. We end up also having our deoxygenated blood is going to leave that capillary network to go back up through the venous return system, up into the right atria, down into the right ventricle, to then be pumped back into the lungs to be reoxygenated and keep this circulation going. Whereas with our capillary networks, our capillary beds, any type of waste products or any type of interstitial fluid left over is going to enter the lymph system. The lymph system is then going to carry all of those different substances throughout the lymphatic network and be processed at what we call the lymph nodes. From that point, all of the tissue will then, or all of the lymph fluid will then be returned to the venous system, where it can then be reprocessed and recirculated into the same manner. Now, when it comes to memorizing each of the white blood cells, and this is not going to be really, I'm not going to test you so much on this when it comes to the purposes of this class. There might be one or two questions on the test coming up. It's not going to be a heavy focus. But when we talk about our white blood cells present in the body, there's going to be a very easy mnemonic to remember the first letter for each of these. And it's going to be, never let my engine blow. So that'll be neutrophil, lymphocyte, monocyte, eosinophil, and basophil. So remember, never let my engine blow. Moving on to cartilage next here. So cartilage is going to be more of our supportive connective tissue here. So just like I mentioned on our previous slide, we break down the word chondrocytes, chondro being our root word meaning cartilage, and then cyte meaning cell. And then if we move on to chondroblasts, if you remember what I mentioned about blast cells, you should note that chondroblasts are going to be the ones that build new chondrocyte cells. Blast cells build. Now, the components of our cartilage is going to be that there's going to be a watery gel, which is going to be called the matrix. Now, this matrix is going to contain a fair amount of what are called chondroitin sulfates, which are going to be made up of a polysaccharide. So these are going to end up coming together with our proteins to make proteoglycans. The proteoglycans are going to be what gives our cartilage its overall structural support. Now, cartilage, much like the epithelial tissue that we covered earlier, is going to have an avascular nature to it, but unlike epithelial tissue, cartilage is not going to be as metabolically active as epithelial tissue, which is why cartilage tends to have a lower regenerative capacity. So if you've ever broken your nose, for instance, you would note that once you break certain types of cartilage, it's just not going to be the same afterward because of that low regenerative capacity. And then, of course, with our three different types of cartilage, we have our hyaline cartilage is going to be the stiff but flexible, very small amounts of flexibility to it. We're typically going to find it at the ends of our bones, especially long bones. We'll talk about that more when we get to our skeleton unit. We also see the nose and the trachea are going to be made up of our hyaline cartilage as well. When it comes to the elastic cartilage, this is going to be the type of cartilage that can distort and return to its original shape, much like the ear. Another example of our elastic cartilage is going to be the epiglottis. So the epiglottis is going to be that cartilage covering that's going to cover the trachea, and it's actually going to fold down over top of the trachea when we actually swallow our food to help prevent food from getting into the trachea, but then it's going to flip back up to its original position once we have finished swallowing in order to allow for a free passage of air through the trachea. We also have our fibrocartilage. This is going to be the toughest and most durable and most immovable type of cartilage. It's going to be pretty commonly seen in our intervertebral discs as well as in our different types of cartilage pads, like we would see between the pubic bones with the pubic symphysis, which again, we'll talk more about the specifics when we get to our skeleton unit. Here we see our histological pictures and our artist representations on the left here and our histological pictures on the right here. These are actual pictures of what the cells look like on a microscopic slide. We take a look at our hyaline cartilage. So we have a hyaline cartilage covering over the top of our humerus, the upper arm bone. When we take that and we take a look at the cross section here, we can see that we have lots of chondrocytes existing in little pockets. These pockets are going to be called lacunae. Lacunae, when roughly translated, is going to mean little lakes. So these little lakes, these lacunae, are going to be where the chondrocytes actually live within the extracellular matrix that we see all throughout the hyaline cartilage, or the ground substance. When we take a look at our fibrocartilage, so we have a cross-cut of our intervertebral disc that we see right here. We see more of our chondrocytes existing in these small little lacunae right here. They're going to be responsible for helping to maintain the overall structure of our collagen fibers that we see running all throughout our slide here. And then we have a cross-section of our elastic cartilage off of this left ear as well. This is going to be where we see our chondrocytes existing in these tiny little lacunae amongst all of these elastic fibers that are going to expand all the way up and down and across our slide here. As far as cartilage goes, let's talk about the overall growth of cartilage, because this is going to be very important for how it lays down the template for the rest of our skeleton to actually grow as well. So the first type of way that cartilage is going to grow in the body is through what is called appositional growth. So appositional growth is going to be the type of growth where the chondroblasts are going to lay down new tissue, adding layers to the surface or the apex of our cartilage tissue that we see right over here. So we can see we have our overall template that we see out here, which is going to include our fibrous tissue out here filled up by our different fibroblasts. And then we have our chondroblasts out here creating new cartilage tissue. Now, what's going to happen is that our original cells, our mesenchymal cells, as they grow, they're going to differentiate into what are called the chondroblasts. And the chondroblasts are going to secrete a new extracellular matrix. Now, this new extracellular matrix is going to end up being added to the external surface of that cartilage that we see out here. And then we have new layers of growth happening from the bottom up on this page right here. So this is going to be an example of our appositional growth. When it comes to our interstitial growth, though, this is going to be where our cartilage is going to grow from within. So we see this happening over here where our chondrocytes actually just go through its own process of division, of mitosis. And as it goes through this mitotic division, it's going to push the resulting daughter cells apart and leave behind new cartilage matrix, new extracellular matrix behind. Moving on to our bone tissue next. This is going to be our osseous tissue. Osseous, or os, is going to be our medical terminology for bone. This is going to be found in our supportive connective tissue category. The primary cells that make up bone are going to be our osteocytes, as well as our osteoblasts and osteoclasts. So just to recap, blast cells build, clast cells are going to do the opposite. They will break down. So our osteoblasts are going to grow new bone tissue, and the osteoclasts are actually going to break it down. It's a very good reason for that, which we'll talk more about when we get to talking about bone growth. Now, the overall matrix of our bone tissue is going to be mostly made up of different types of salts, especially when it comes to different types of phosphate and calcium salts. And then there's going to be a fair amount of collagen fibers found in our bone as well. This is going to be important because the collagen fibers help to give our bones a little bit of flexibility to them, and that's very important because we don't want to have brittle bones. They're very susceptible to breakages that way. So we want to have a little bit of elasticity, a little bit of flexibility, and that comes by way of the presence of collagen fibers. Our bone tissue is going to be very vascular. This is very good because this is going to give our bone tissue a high regenerative capacity, which is why we can actually break bones or fracture them. And in some instances, if surgery is not needed, we simply just cast them up and give it some time. And then over time, the bone will actually heal and resorb all of the old material and rebuild the new bone. Surrounding all of this bone tissue is going to be what we call a periosteum. Peri means around, and then os meaning bone. And then the tium here is going to end up being our connective tissue root word. And then we have, of course, our two different types of bones are going to be our compact bone and the spongy bone. The compact bone is going to be, of course, the most dense one that we typically think of when we think of bone. And then we have our spongy bone, which is going to have, as the name implies, a spongy, punched out like appearance to it. We see those two different types of bone tissues on our slide here. We can see over on this left side of the screen, we are looking at a humerus bone, an upper arm bone. This is going to be our proximal humerus, the one closest to the shoulder or our point of reference. And then the distal end down here being the one that articulates with the ulna to create the elbow. But when we take a cross section of this humerus, known as a long bone, we can see our two different types of bone seen inside. We have our compact bone is going to create the outer wall that we see out here. We end up having our circumferential layers, the ones that go the entire circumference around the bone itself, as well as our concentric layers, which are going to be these circular layers that we see in the middle here. That's going to be our compact bone. And then our spongy bone is seen in the middle because our spongy bone, because it's got this punched out appearance to it, this is going to be where we find a lot of our bone marrow. The bone marrow is mostly going to be made up of adipose tissue, which will be responsible for the creation and formation of new blood cells. On the right side out here, we can see a close-up picture showing that periosteal covering on the outside of our bone tissue. There's a very good reason for why we have the periosteum. It's going to create a bit of a division from the bone from the rest of the body to help do things like decrease the risk of bone infection and also provide a little bit of shock absorption as well. So that way, if we ever, for instance, hit our funny bone on a table or something, even though it still hurts, it at least hurts less because we have a periosteal covering. Looking at the histological cut of our bone tissue, we can see that each of these concentric layers to our bone tissue, to the dense part, is going to exist in what we call an osteon. So that osteon is going to be what we call a functional unit of bone tissue, where we see a couple of concentric layers surrounding what we call the central canal. The central canal is going to be how our different arteries, veins, and nerves are actually able to enter and traverse the length of the bone. And then connecting all of our different layers of matrix, we have these different small canals that we call canaliculi. So canaliculi are roughly translated as little canals. And in between these canaliculi, these areas that connect our different layers, we're going to see our osteocytes residing in here as well, within the lacunae. Let's cover a couple of vocabulary terms in reference to different types of membranes. So of course, with our membranes, we're typically talking about different types of epithelial tissues supported by the underlying connective tissues. When it comes to mucous membranes are going to be the type of epithelial tissue that's going to line our exterior passageways. We're thinking about things like the nasal cavities and as well as the oral cavity or your mouth. Those are a quote-unquote exterior passageway because they open up to the exterior around the body. When it comes to things like the serous membranes, these are going to be the types of membranes lining the body cavities, so lining the inside of the thoracic cavity as well as the abdominal pelvic cavity. We'll find the serous membranes. Our cutaneous membrane is going to be the one covering the body, so this is going to be our skin. It's going to be very dry as a result. And then we have synovial membranes in the body as well. Synovial membranes are going to be the type of membrane surrounding what's called the synovial joint capsule. So the synovial joint capsule is going to be an area around larger joints as well as different smaller joints that's going to serve a couple of different purposes like protection, lubrication of the joints to reduce friction, as well as different types of physiologic or metabolic processes as well. We'll talk more about synovial joints when we get to our skeletal unit. And then, of course, we do have what are called fascia. So fascia are going to be connective tissue layers surrounding all of our different organs as well as our different types of muscles. So these are going to be pretty important. The note here about may be more important than we realized, that's kind of the rest of the healthcare and health science community really catching up in terms of the importance of fascia. Some medical or some healthcare disciplines have been all over fascia for a while here. So we're just making sure that we, as a community or as a research community, we're all getting caught up. All right, we're almost there at the end here, but we need to talk about muscle tissue before we get to the end here. So we have three types of muscle tissue in the body. It's going to be our skeletal muscle tissue, our cardiac muscle tissue, and our smooth muscle tissue. Let's talk about the first characteristic of our muscle tissue here. Voluntary versus involuntary. Voluntary muscle tissue is going to be the type of tissue that we consciously move. So this is going to be our skeletal muscle tissue, named because it's going to be what connects to and moves the skeleton. So we're thinking about muscles like your hamstrings, your biceps, your latissimus dorsi. These are going to be types of skeletal muscle tissues that we move on a voluntary basis. Now, this is different from involuntary movement for things like cardiac muscle tissue and smooth muscle tissue because these muscle tissues contract and move without us needing to think about it. So we're focused on things like with the cardiac muscle tissue, because it beats on an involuntary basis. This is very good because we don't have to just stop every couple of seconds and think I need to pump my blood. It just happens automatically. Same thing with smooth involuntary muscle tissue. We don't have to think about moving our food throughout our gastrointestinal tract. Instead, the smooth muscle that lines our GI tract will involuntarily contract to move our food throughout the GI tract. Very good, so that we don't have to think about stopping and moving our food through our GI tract. When it comes to the skeletal muscle tissue, back here to the skeletal tissue, we're going to note a couple of key characteristics as well. They're going to have a very long, very cylindrical appearance to them. They're also going to have a large number of what are called striations, these lines that go perpendicular to the muscle fiber, which when we talk about muscle fiber and muscle cells, those are one and the same. A muscle fiber is a muscle cell. So when it comes to those striations on skeletal muscle fibers, those are areas that are going to be heavy in what are called myofilaments, the specific types of structures responsible for powerful muscular contraction. So our skeletal muscle has a large degree of these myofilaments, and as a result, it's going to need a fair amount of control and energy production, which is why our skeletal muscle fibers are going to have a multinucleate appearance. There are going to be multiple nuclei for each of these muscle fibers to help control the rates of contraction, strength of contraction, as well as to properly distribute the energy needs for these massively powerful skeletal muscles. When it comes to the cardiac muscles, though, these are going to be rather short and have a branched appearance to them. The branched appearance is important because we need to make sure we have plenty of communication happening through what we call the intercalated discs. Intercalated discs are going to be these very dark areas that we see right here, unique to cardiac muscle, because through the branched portions and the intercalated discs, there's going to be a fair amount of regulation of the transmission of action potentials. This is important because we need to have the heart beat in synchronous fashion. We need to make sure that if one ventricle is going to undergo contraction, that the entire ventricle contracts, not just half of the ventricle shortly followed by the other half. We need the whole ventricle to contract as one unit. So we have all of these branches and all of these intercalated discs to assist with that. Now, because the cardiac muscle doesn't have to be quite as powerful as skeletal muscle, it's going to have a lower amount of myofilaments to it, and as a result, a lower amount of nuclei. So instead of having multiple nuclei per muscle fiber, we're going to have just the one instead. And then when it comes to our smooth muscle tissue, this is going to differ in morphology because the smooth muscle fibers are going to be rather smaller and spindle shaped. There will be no striations. because their contractions will happen in a different manner, and they will also be uninucleate in fashion. Now we have our final type of tissue in the body. We have our nervous tissue. This is my favorite type of tissue because this is the thing that I deal with the most in my practice. So when it comes to nervous tissue, most of it, almost all of it, is going to be contained within the brain and the spinal cord, and there's going to be two primary categories for our nervous tissue. We have our neurons, which are going to be the most ubiquitous and the most physiologically active, and then we have our neuroglia as well. The neuroglia are going to be the different types of support cells that we have in the body. So with our neuroglia, we have things like our astrocytes that we would see right here that are going to maintain the physical structure of our nervous tissue. We also end up having our different types of neuroglia that are going to be responsible for functioning as the white blood cells of the nervous system. They're going to perform phagocytosis or phagocytosis to help eat up any invading pathogens. This is very important because we have what's called a blood-brain barrier surrounding our central nervous system, the brain and the spinal cord. So we can't have white blood cells just crossing over into our nervous tissue to fend off invading organisms. So we have neuroglia to function for that as well. But our neurons are going to be the ones most specialized for the conduction of electrical signals known as action potentials. And this is a picture of our basic neuron that we see right here. We have a couple of primary components. We have what we call the cell body all the way on the left over here. This is going to be where we see much of our metabolic activity happening here. A lot of our mitochondrial activity, a lot of our nuclei activity is going to happen in the cell body here. The cell body is going to have a couple of attachments, though, called dendrites. Dendrites are going to be attachments that receive incoming action potentials. Incoming signals are going to come and be collected by the dendrites. Once they are collected by those dendrites, the cell body will then process that information, and then it may choose to propagate or continue the signal, at which point the axon hillock down here is going to create a new signal, a new electrical signal or action potential, which will travel away from the cell body down what we call the axon that we see right here. And that signal will travel all the way down until it reaches the axon terminals that we see out here. Let's wrap this up today with talking about what happens to tissues when they go through injury. So there's going to be two primary phases or two primary components to tissue injury and repair, and that's going to be inflammation and regeneration. So the first portion is going to be whenever there's some sort of injury, we're going to use the epithelial tissue of the skin as our example. We have an injury happen. Our little kid has scraped their knee, as kids are wont to do. And what's going to happen first is we have a general exposure to external pathogens and toxins. So this is a big reason why whenever we have an external wound, we want to make sure that we clean it first to help decrease this chance of having an exterior or external infection. But in the absence of cleaning the wound, we are going to see what's called an inflammatory process where we have a mast cell activation. The local mast cells to the area are going to secrete different inflammatory markers like histamine, heparin, and prostaglandins. So what this is going to do is it's going to set off an inflammatory cascade. Now, inflammation, many people think of it as being a bad thing, but it's really going to be dependent on the context. If we have too much inflammation in the body as a result of things like lifestyle factors, dietary choices, and things like that, inflammation can be bad. But in the instance of acute injury, inflammation can actually be a really good thing because it's going to be the first portion of what sets the body up to reach the regenerative or the healing stage. So the initial inflammatory process in this situation, an injury, is going to start with having an increased blood flow to the area because the body wants to actually send more platelets to the area, more blood platelets to actually build up and create a clot. That is known as our positive feedback loop, increasing the overall response until we have our desired end goal. What's also going to happen is that the blood vessels in the area are going to become more permeable. This is so that the white blood cells can actually leave those areas, leave those vessels, and then go through phagocytosis and eat up those invading antigens and those invading pathogens. There's also, as a result of this increased permeability, we're going to see an increase in the temperature to the area as well as an increase to the overall delivery of nutrients to those damaged tissues so that we can remove all of those toxins and wastes and begin the healing process where scar tissue is laid down and over time then remodeled into new tissue. So that's going to wrap it up for today. That's going to be our chapter 4. So make sure that you are keeping up with your SOA and keeping up with your Pearson assignments. There will be a homework and a quiz assignment for chapter 4 in Pearson MyLab. Make sure you get that completed as soon as possible. Anyway, I will see you again for chapter 5. Have a good one.